Hello there, I am Mustafa Abdurrabbu, lecturer of cardiology at Cairo University. Today we will talk about IV fluids. This lecture was presented in the acute cardiovascular care course at Cairo University in January 2023. Bismillahirrahmanirrahim. In the name of Allah, the Most Merciful, we will start this lecture. Our lecture today will be divided into 5 parts. In the beginning, we will start with the key concepts, then gathering informations, taking action, dealing with consequences, and question and answers. Question and answers will be available only for those attending with us the lecture. As an introduction, we know that fluid resuscitation using IV fluids is considered the mainstay of therapy in severe hypovolemia. Severe hypovolemia occurs when loss of blood or extracellular fluid. This can occur in the form of bleeding, burn, or excessive use of diuresis, leads to decreased peripheral perfusion. This has to be differentiated from hypovolemic shock, where severe hypovolemia becomes severe enough to cause significant tissue hypoperfusion, organ dysfunction, which can lead to elevated lactate, metabolic acidosis, etc. In severe hypovolemia, or in the more severe form, the hypovolemic shock, delayed fluid therapy and delayed action can lead to ischemic injury, which can lead to irreversible shock. So our first step is gathering information. This is how you deal with any problem. The first step is gathering information, collect all the data from all the available sources. For management of severe hypovolemia, you should always assess and treat the underlying cause. You should search for bleeding and correct the site of bleeding, compress it, or even call for surgical intervention to treat this condition. Second step is identifying electrolytes and acid-base disturbances. Third step is assessing the volume deficit. The fourth step is choosing the type of IV fluids and the rate you will start and the rate you will continue. By gathering this, by doing the first 3 steps, you can efficiently choose the type of IV fluids you would use and the rate you would like to start with. The electrolytes that should be evaluated usually in the case of severe hypovolemia or hypovolemic shock, we go for a full panel of laboratory investigations. However, what really impacts our decision in choosing the type of IV fluid is the sodium, either the presence of hypovolemia, hyponatremia or hypernatremia, potassium, the presence of hypo or hyperkalemia, presence of acidosis and alkalosis, which is reflected from the bicarbonate level, and the chlorine. The chlorine is a rising site of research in medicine, especially when it comes to the volume status, the hypovolemia and the hypervolemia. It is one of the most abundant electrolytes in the body. The third step is evaluating the fluid deficit. Evaluating the fluid deficit can be easily performed by revising the body weight if electronic medical records is present, or by asking the patient or the relative, evaluating the body weight today and comparing it with the body weight in the previous days. This is mainly beneficial in the case of non-hemorrhagic shock when the fluid deficit is not obvious. However, if the patient is bleeding and you have dressings or clothes you can roughly evaluate how much fluid were lost. What does tomorrow mean is that in spite of if giving fluids, you should know when you will stop giving IV fluids, and what if the patient is getting over resuscitated, and this can be easily monitored by evaluating body weight on daily basis. Another important thing is blood pressure. Blood pressure is extremely beneficial in evaluating the presence of shock, the presence of hypoperfusion, and the success of our intervention. If the blood pressure is severely dropped, you should go for using vasopressors as Levophed, which is noradrenaline, adrenaline, or other vasopressors. Urine output monitoring and the urine color and the urine concentration is very beneficial in reflecting the fluid status and the response to fluids. However, if clinical data is not sufficient, using the IVC size and the IVC response to inspiration can usually become very beneficial in evaluating the fluid deficit in the patient. If the patient is having a severely collapsed IVC, so the patient is having a significant fluid deficit and he will require correction. However, if it is 2.5 centimeters and it doesn't collapse with inspiration, you should think of other diagnoses. Lactate is an extremely beneficial investigation in all kinds of shock state. It defines the presence of shock state, and it also helps us to know if we are going in the right way or not. If the lactate is rising despite of your intervention, you should think that you are doing something wrong or there is something missing. If it is declining, you are probably doing it right. Urinary sodium reflects the ability of the kidney to concentrate urine. What does this mean? If the urinary sodium is abundant, this means that the fluid content of the intravascular volume is sufficient, so the kidney is getting rid of fluids and sodium. However, if the sodium is less than 15 millimole per liter, this means that the kidney is keeping the sodium in the intravascular volume, which means that the intravascular volume is retracted. Our second major step to take is taking action. We all know that action changes things. We cannot just observe things getting worse and worse without taking the appropriate action. So what is the action in our dilemma here? It is choosing the type of IV fluids. What are the types of IV fluids? I have three major categories of IV fluids, which is crystalloids and colloids and blood products. Crystalloids are a broad spectrum of products, with the most famous is saline solution, the normal saline solution with 0.9% sodium chloride concentration. However, other solutions are present: half normal saline, hypertonic saline, which is 3% solution, buffered crystalloid solution, which is Ringer lactate, Ringer acetate, plasma elite, and Hartmann solution. These are by far the most available, the most cheap IV fluids that are present, and on top of that, they are the most studied types of solutions. And comes at the top is a normal saline solution. Other crystalloids include the dextrose, 5%, 10%, 25%. The other type of IV fluids is colloids. Colloids have a higher oncotic pressure than crystalloids. The most commonly used is albumin-containing solutions of 4% solution, hyperoncotic starch, which is currently no longer in use in most countries, dextran, and gelatin-containing colloids. The most famous kind of IV given fluids is blood products. These blood products can include blood, whole blood, packed RBCs, plasma, etc. etc. Another kind of blood products is blood substitutes. So what we will choose for our patients? If the patient is having obvious hemorrhage, like being injured like being a victim of a road traffic accident or so, we usually start saline for resuscitation. This is can be usually done on site. Then blood products, which usually requires matching if you are giving packed blood, packed RBCs, or plasma if packed RBCs are not present, can be given. They have a very good oxygen carrying capacity and they can expand the intravascular volume sufficiently. However, they are prone for reactions, they are also prone for infection spread, and they need cross matching. A more or less newer concept is acellular blood substitutes. What are acellular blood substitutes? As you can see, this is the hemoglobin. It consists of 4 subunits. By genetic engineering, this hemoglobin can be given in some forms with oxygen carrying capacities in the IV fluid without being toxic to the kidneys. This has more extended use in veterinary applications. However, it is very limited in human applications. It is still now under the research panels. So what if we have no hemorrhage? Then we usually start using crystalloids. Example, 0.9% saline solution with or without crystalloid dextrose, buffered crystalloids, or buffered crystalloids. We usually give large volumes, 1 to 2 liters or 2 to 3 liters of normal saline, and if there is hemorrhage we give 1 liter of normal saline over the first encounter. Then we ask for blood products if needed. The second option is colloid containing solutions. We usually don't go for colloid containing solutions except if saline fails. Hyperoncotic starch solutions increase the risks of acute kidney injury, the need of dialysis, and mortality. So the most common question to be asked from fellows is whether to use crystalloids or colloid containing solutions. Actually, this was studied in the crystal trial and the safe trial and multiple meta-analyses. The crystal trial randomized intravenous crystalloid, saline, or colloid solutions, and it found that no difference in 28 days mortality or the need for dialysis. Colloids showed more days free of mechanical ventilation and vasopressor therapy. However, this was not significant. The safe trial, however, was more specific. Instead of using any kind of colloids, it used 4% albumin solution, and instead of using any kind of intravenous crystalloid in crystal had saline as the most used. However, safe used only saline, normal saline. They found that there is no difference in mortality at 28 days, no evidence of multi-organ failure difference, and it didn't impact the duration of hospitalization. However, an observation was found, however, it didn't reach any statistical significance, showed worse outcome in head trauma with albumin-containing solutions. What does other trials tell us? Other trials tells us that there is a slight increase in mortality with albumin. However, we can go that there is no large difference between both types. It should be noted that crystalloids are extremely cheaper and there is no hyperreactivity with crystalloids. So when we use colloids, only when crystalloids fail or if hypoalbuminemia is present or expected, as in patients with hepatic disease or burn or such, you should go with albumin containing solutions if it is available for you. However, if you are in doubt, go with crystalloids till the laboratory investigations is present to you. So in crystalloids, what shall we choose? Is it saline, normal saline, or is it buffer crystalloids or other types? As you already know, hypertonic saline is available and it is usually used for severe hyponatremia. And it is its indication. However, normal saline compared to buffer crystalloids shows higher chloride, more sodium, which can lead to more metabolic acidosis. Buffer crystalloids has more bicarbonate, which can lead to alkalosis, less sodium content, which can promotes hyponatremia, less chloride, and more potassium. There is no clear difference if small volume of saline or buffered crystalloids were given. The cutoff is 2 liters. However, you should usually individualize your decision about which type you will give based on the electrolytes and the acid-base data. The data from major trials showed no clear difference between the two types. There is even minimal and non-significant difference between buffered solution and saline and the different types. However, this is not enough for recommendation of saline versus buffered crystalloids. So, how much fluid we will give? It is recommended that we give 2 to 3 liters over the first 3 hours, unless we have a patient with impaired ventricular function, patient with acute kidney injury, when you are in fear of getting over resuscitation and patient can get in pulmonary edema. So you give 2 to 3 liters over the first 3 hours and then you follow up and see if you are giving lower or higher volumes. Where does this data come from? It came from most sepsis trials, and these sepsis trials didn't show any difference between using normal saline or buffered crystalloids. No difference between giving 2 to 3 liters over the first 3 hours or giving 5 liters, which was proposed before. However, there is no difference in data. After that, you should adjust the rate according to the response. So, after giving fluids or after taking any decision, you should always think about dealing with consequences. Consequences is the result of your action, and you should always anticipate the presence of problems and have a plan to deal with. So, what are the consequences of using saline? Saline is not a heavenly product, it is a human-made product, and in spite of it being beneficial, it can have some consequences. The most known consequence is hyperchloremic metabolic acidosis. So, what is hyperchloremic metabolic acidosis? Simply, as saline contains too much chloride, this chloride creates hydrochloric acid and it is not buffered enough by the buffer system in our blood. So hypercholemic metabolic acidosis kicks in. It It is usually a very mild form of acidosis, and it can be extremely easily treated by shifting to other crystalloids if needed. However, it can precipitate hyperkalemia due to the transcellular shift of potassium, and this is of a significant importance only in patients with kidney disease. So you should keep more cautious with patients with acute or chronic kidney disease. The other proclaimed consequence of saline is presence of peripheral edema. Why does this occur? Because of significant extravascular distribution of the normal saline. What does this mean? As you know that saline is a crystalloid. It's water with sodium chloride. Sodium chloride has no oncotic pressure almost, so it moves by diffusion across the plasma membrane, the cell membrane, and gets easily into the extravascular compartment. And this explains why we give 2 to 3 amounts of the volume that to be given with the colloids. However, this is not necessarily a bad thing. Why? Because when the patient loses fluids, this is not exclusively from the intravascular volume. However, it comes also from the extravascular volume. So when we give fluid, we should also think about replenishing the extravascular volume as we are replenishing the intravascular volume, and crystalloids generally will do this job sufficiently. You should fear peripheral edema when you are aware of over-resuscitation, not in the general situations. The other option, as we said before, is buffered crystalloids. Buffered crystalloids have lower sodium content, so we can expect hyponatremia. Edema is present either with Ringer lactate or saline for the same reason. And the alkalosis can be present due to the presence of bicarb in the solution. This can make you choose Ringer lactated Ringer over saline in cases of patients presenting already with metabolic acidosis. Another important consequence is over-resuscitation. How can we avoid over-resuscitation? This is a simple, however, a tricky clinical question. You should look to the neck veins. Neck veins is important. Why? Because it can help us follow the volume status of the patient, and it can help us achieve our target. If we are having a patient with no visible neck veins at the sitting position, this is at the sleeping position, this is probably a dehydrated patient. If you have a patient with a neck veins to the angle of the mandible while the patient is sitting, this means that the patient is probably overloaded. However, you can follow up if the patient is getting enough fluids by the rise of neck veins, and if you are giving diuretics by the declining of the level of neck veins. So always look for the neck veins on the first presentation and during follow-up. The other simple tool is following up the body weight. If you inserted a central venous catheter, you should monitor actually the central venous pressure. You should always monitor urine output when you are giving fluids or giving diuretics. And if you forgot all of this and the patient got of pulmonary edema, it is definitely your fault. So when you should stop? You should stop giving IV fluids in large volumes with clinical improvement If the patient had an impaired conscious level, agitated, and he improved, the mean arterial blood pressure should be above 65 but not above 70. The heart rate is getting back to its normal range. There is adequate urine output and the lactate levels is improving. If urinary sodium is more than 15 millimole, you have probably resuscitated the patient sufficiently. This is our fourth part. This is for those who attended the lecture. However, you can send us question and answer in the comments. Don't forget to subscribe and share, and if you have any question, you are more welcome to answer it. Thank you, and I hope to see you again in other videos.